To fully understand and appreciate the clinical benefits of counterpulsation, we should know the sound understanding of heart's anatomy, the cardiac cycle, coronary perfusion, and the events associated with ventricular failure. The heart is located in the mid-mediastinum, and the base of the heart is at the level of second to third intercostal space. The apex of the heart extends to the level of the fifth to sixth intercostal space. The heart is divided into four chambers, the right and left atrium and the right and left ventricle. Valves connect the four chambers of the heart. The valves between the atria and ventricles are called the atrioventricular valves. They include the mitral valve, which connects the left atrium to the left ventricle, and the tricuspid valve, which links the right atrium with the right ventricle. Two other valves lie between the ventricles and the major arteries. These semilunar valves include the aortic valve between the left ventricle and the aorta, and the pulmonary valve, which is located between the right ventricle and the pulmonary artery. All of the heart valves open and close in response to changes in pressure within the heart and the aorta. The venous blood enters the right atrium of the heart through SVC and IVC. The blood moves into the right ventricle and pumped through the pulmonary artery to the lungs, where it is getting oxygenated. The oxygenated blood from the lungs proceeds through the pulmonary veins to the left atrium. It then travels into the left ventricle, which pumps oxygenated blood into the ascending aorta for transport to the rest of the body. The cardiac cycle is defined as the sequence of the alternating contraction and relaxation of the atria and ventricles in order to pump blood through the body. The cardiac cycle is comprised of systole and diastole. These stages are further divided into 5 smaller stages called atrial systole, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, and ventricular filling or late diastole. This is the first phase of the cardiac cycle. During atrial systole, the mitral valve is opened to allow the blood flow from atrium to ventricle. The atrium contracts in response to an impulse from the SA node. Atrial depolarization translates to the P wave on the ECG, and atrial contraction immediately follows. As atrial contraction begins, the ventricle is already about 70 to 80% full of blood. When the atrium contracts, additional blood is ejected into the ventricle, increasing the ventricular volume by another 20 to 30%. This is often referred to as atrial kick. After atrial contraction is completed, the atrial pressure begins to fall, causing a pressure gradient reversal across the AV valves. The AV valves close when intraventricular pressure exceeds atrial pressure. During the time period between the closure of the AV valves and the opening of the aortic and pulmonary valve, ventricular pressure rises rapidly without a change in ventricular volume. Hence, it is called as isovolumetric contraction. During this phase, all the valves are closed. The contraction of the ventricular muscle has raised the pressure within the ventricle to the point that is greater than the pressures in the pulmonary artery and the aorta. Blood is pumped from the heart, opening the pulmonary and aortic valves. Pressure generated by the left ventricle will be appreciably greater than the pressure generated by the right ventricle, since the existing pressure in the aorta will be so much higher. During the early phase of ventricular diastole, as the ventricular muscle relaxes, pressure on the remaining blood within the ventricle begins to fall. When pressure within the ventricles drop below the pressure in both the pulmonary artery and aorta, blood flows back towards the heart, producing the dichrotic notch in the blood pressure tracing. The semilunar valves close to prevent backflow into the heart. Since the atrioventricular valves remain closed at this point, there is no change in the volume of blood in the ventricle. So, the early phase of the ventricular diastole is called the isovolumic ventricular relaxation phase. In the second phase of ventricular diastole, called late ventricular diastole, as the ventricular muscle relaxes, pressure on the blood within the ventricles drops even further. Eventually, it drops below the pressure in the atria. When this occurs, blood flows from the atria into the ventricles, pushing open the tricuspid and mitral valves. As pressure drops within the ventricles, blood flows from the major veins into the relaxed atria and from there into the ventricles. Both chambers are in diastole. The atrioventricular valves are open and the semilunar valves remain closed. The cardiac cycle is completed. The first wave on an ECG is the P wave, indicating atrial depolarization in which the atria contract, otherwise known as atrial systole. The P wave is the first wave on the ECG because the action potential for the heart is generated in the sinoatrial node located on the atria, which sends action potentials directly through Bachmann's bundle to depolarize the atrial muscle cells. The QRS complex refers to the combination of the Q, R and S waves and indicates ventricular depolarization and contraction, which is otherwise known as ventricular systole. The Q and S waves are downward waves, while the R wave and upward wave is the most prominent feature of an ECG. The T wave indicates ventricular repolarization in which the ventricles relax following depolarization and contraction. The ST segment refers to the gap between the S wave and the T wave and represents the time between ventricular depolarization and repolarization. An elevated ST segment is the classic indicator for myocardial infarctions, though missing or downward sloping ST segments may indicate the myocardial ischemia. Heart failure can be caused by structural heart disease, coronary artery disease, cardiomyopathy or conduction disorders, more often than not requiring the surgical correction. Myocardial oxygen supply must balance myocardial oxygen demands to meet the heart's metabolic requirements. Local autoregulation is the primary mechanism the heart uses to maintain the critical balance of supply and demand. The myocardial oxygen demands are affected by heart rate, afterload, preload and contractility. Left ventricular failure occurs when the heart is unable to meet the metabolic demands of the body. It is the common indication for intra-aortic balloon counterpulsation. Left ventricular failure can result from myocardial insult or injury or any other conditions that causes a disease in heart pumping deficiency. As left ventricular failure progresses, a greater imbalance develops between the oxygen supply and demand in the myocardium. The goal of treatment for the left ventricular failure is to restore this critical balance of oxygen supply and demand to stabilize the patient. Left ventricular failure occurs in 3 stages. Stage 1 vasoconstriction, stage 2 hypervolemia and stage 3 tissue hypoxia. Stage 1 is manifested as vasoconstriction leading to decreased pumping efficiency, increased LV volume and pressure. These physiological events activate baroreceptors leading to increased heart rate, increased afterload or SVR, increased myocardial oxygen demand and ultimately an increase in preload LVEDP. Stage 2 leads to hypervolemia as the heart tries to compensate with the additional afterload. There is a decrease in cardiac output and glomerular filtration pressure, further activating the renin-angiotensin system. There is an increase in sodium and water reabsorption, leading to an increase in preload and afterload. There is a decrease in cardiac output, decrease in oxygen supply, increase in heart rate, and increase in oxygen demand, and there is an increase in pulmonary artery wedge pressures. The final stage of LV failure is the manifestation of tissue hypoxia. Decreased cardiac output, decreased mean arterial pressure, decreased oxygenation coupled with pulmonary edema causes the acceleration of anaerobic metabolism, causing lactate acid production, tissue anoxia, and finally the tissue death. It's ideal to insert the intra-aortic balloon in stage 1 or by stage 2 so that we can prevent the final stage of heart failure. What is IABP? The intra-aortic balloon pump is a circulatory assist device that is used to support the left ventricle. The IABP uses counterpulsation where aortic blood is displaced with the inflation and deflation of the balloon catheter, which is timed to the cardiac cycle. The overall aim is to improve the myocardial function by increasing myocardial oxygen supply and decreasing myocardial demand. Overall, IABP counterpulsation is expected to increase diastolic pressure by 30% and decrease the systolic pressure by 20% and improve cardiac output by 20%. In addition, it improves the cardiac output, it increases coronary perfusion pressure, it increases systemic perfusion, it reduces mitral regurgitation and reduces afterload, which will subsequently decrease the left ventricular workload. Intra-aortic counterpulsation is the most commonly used circulatory assist device that is used today. The balloon consists of a polyurethane membrane on a vascular catheter that is positioned in the distal thoracic aorta. The catheter is connected to a pump console which monitors the patient's heart rhythm and arterial blood pressure. The intra-aortic balloon is timed to inflate and deflate in synchrony with the cardiac cycle. This counterpulsation increases myocardial oxygen supply and decreases myocardial oxygen demand of the heart. When choosing the IABP catheter, there are two factors to be considered: the size of the catheter shaft and the balloon volume. The smaller the size of the French catheter, the impact will be less on the distal blood flow to the lower limb. The main factor affecting balloon volume is the length of the balloon membrane. The patient's height is used as the guideline for selecting the balloon membrane volume. Why helium is used in the IABP? Helium is used as it is easily dissolves in the blood than air and prevents the risk of air emboli if the catheter ruptures. The advantage of helium is its lower density and therefore a better rapid diffusion coefficient. It minimizes the resistance, which can help in rapid inflation and deflation. When the decision is made to introduce IABP, the IABP is usually inserted percutaneously using the Seldinger technique with the strict aseptic technique. The most common site of the access is the femoral artery. Alternative access sites include brachial and axillary artery. Percutaneous techniques and open surgical aortic approach can be performed. After successful puncture of the chosen artery, a J-typed guide wire is inserted to the level of the aortic arch. A combined dilator and sheath combination is then inserted, allowing the balloon to then be fed over the guide wire into the descending aorta. The IABP catheter positioning has to be precise. The tip of the IABP catheter has to be positioned approximately 1 to 2 cm distal to the left subclavian artery or in between the second or third intercostal space. The base of the IABP catheter has to be positioned above renal arteries as shown in this figure. If the IAB catheter is malpositioned, that is, it is positioned too far inside, it can cause subclavian and vertebral artery occlusion. If the IABP catheter is not positioned far enough, it can cause mesenteric and renal artery occlusion. The correct positioning of the IABP catheter can be confirmed through an X-ray since the balloon tip is made up of radio-opaque material. As you can see, on daily chest X-ray, the tip should be visible between the second and third intercostal space in the level of carina. Let's see the indications for inserting IABP. First of all, it's the medical indications like cardiogenic shock, pre-shock syndrome, threatening extension of MI, unstable angina, intractable ventricular dysarrhythmias, septic shock syndrome, cardiac contusion, bridging device to other mechanical assist devices like ventricular assist devices, and support during transport. Prophylactic support for coronary angiogram, coronary angioplasty, thrombolysis, high-risk interventional procedures like stent insertion. And cardiac support for hemodynamically challenged patients with mechanical defects prior to correction of valvular stenosis, valvular insufficiency, ruptured papillary muscle, ventricular septal defect, or LV aneurysm. The surgical indications includes post-surgical myocardial dysfunction, support for weaning from CPB, cardiac support following correction of anatomical defects, maintenance of graft patency post-CABG, pulsatile flow during CPB. The contraindications for IABP includes the absolute contraindications like aortic regurgitation or insufficiency. In this physiology, raising AEDP would result in increase of regurgitant factor, thereby increasing the workload of the heart. In instances of mild AI, a decision can be made if the benefits outweigh the risk. Aortic dissection precludes the IABP insertion. Attempting to place an IAB in this situation may lead to the placement in the false lumen or at the very least increase circulation into the false lumen. The relative contraindications includes severe peripheral vascular disease, unresected thoracic abdominal or thoracoabdominal aneurysm, sepsis or infection, severe thrombocytopenia, coagulopathy or coagulopathic disorder, severe atherosclerosis, end-stage terminal disease, end-stage cardiomyopathy unless bridge to transplant or destination therapy. The hemodynamic effects of IABP are increased cerebral blood flow, increased coronary blood flow, increased cardiac output, increased renal blood flow up to 25%. During hemorrhagic shock, there will be an improvement in vasoregulatory control of splenic blood flow. Decreased left ventricular afterload, decreased aortic systolic blood pressure, decreased pulmonary capillary wedge pressure, decreased LV volume, decreased LV end diastolic pressure, decreases the wall tension of left ventricle. The complications of IABP are it can cause aortic valve dissection, aortic valve rupture, or vascular injury to the aortic wall. It can also cause embolic events through thrombus, plaque, or through air. IABP rupture can cause helium embolus, catheter entrapment, infection, or hematologic problems like bleeding and thrombocytopenia. Main complication of the IABP, that is the obstruction. While placing the IAB catheter in a malpositioned way, whether it is too high means it can obstruct the left subclavian artery and carotid arteries. If it is malpositioned too low, the obstruction of renal and mesenteric arteries are noted. Compromised circulation due to the catheter placement can cause ischemia, compartment syndrome. Principles of counterpulsation. When the patient is supported with the intra-aortic balloon counterpulsation, ideally both the ECG and arterial blood pressure are monitored on the pump console. These signals will help the pump to identify the phases of the patient's cardiac cycle. Timing and trigger is very important for intra-aortic counterpulsation. Timing refers to the inflation and the deflation of the balloon in relation to the patient's cardiac cycle. Timing can be visualized on the arterial blood pressure waveform. Trigger is the physiologic signal from the patient that identifies the new cardiac cycle, and ECG is the preferred source since the electrical precedes and initiates the mechanical event. The R wave on the ECG represents the onset of the new cardiac cycle and is referred to the trigger event. In circumstances where the ECG is not available for the use as the trigger, the arterial blood pressure may be used to synchronize the patient's cardiac cycle. Inflation of the balloon is triggered by the beginning of the diastole, which correlates with the middle of the T wave. The balloon is timed to deflate at the very end of the diastole. This correlates with the R wave on the ECG, and this is the most commonly used trigger for balloon deflation. During the dicrotic notch, the IABP balloon inflates. This is timed with the ECG. Usually, the end of the T wave is used as the marker that systole has finished. Deflation occurs at the end of the diastole after systole, resulting in reduction of aortic end diastolic and systolic pressures. The hemodynamic consequence of inflation of the balloon is an increase in coronary blood flow and therefore increasing the myocardial oxygen supply. Deflation of the balloon just before systole results in decreased ventricular afterload, which decreases myocardial oxygen consumption and increases the cardiac output. The benefits of accurately timed inflation are: coronary artery blood flow and pressures are increased. Increased perfusion may increase the oxygen delivered to the myocardium. Increased diastolic pressure also increases the perfusion to distal organs and tissues, that is, increased urine output and good cerebral perfusion. Coronary collateral circulation is potentially increased from the increased coronary perfusion pressure. Systemic perfusion pressure is also increased. The benefits of accurately timed deflation are: the pressure that the left ventricle must generate is less throughout the systolic phase. Therefore, afterload is reduced, which decreases the myocardial oxygen demands. The IVC phase is shortened, which decreases the oxygen demands. Reduced afterload allows the LV to empty more efficiently, so stroke volume is increased. In addition, preload is reduced if elevated. Enhanced forward cardiac output also decreases the amount of blood shunted from left to right in cases of intraventricular septal defects and incompetent mitral valve. Mainly, inflation of balloon increases coronary perfusion by providing more oxygen to myocardium. You can see inflation and deflation of the intra-aortic balloon in this small animation. When the balloon inflated during diastole, the left ventricle is relaxed and the coronary arteries are filling with oxygenated blood. Balloon inflation displaces blood back to the coronary arteries to improve myocardial oxygen supply and increase aortic diastolic pressure. This effect is called as diastolic augmentation. Balloon deflates just prior to the left ventricular ejection. With rapid deflation of the intra-aortic balloon, the end diastolic pressure in the aorta is reduced. This reduction in pressure decreases the resistance against which the ventricular has to work. Subsequently, the systolic wall tension or afterload of the ventricle is also reduced. These effects results in a decrease in myocardial oxygen demand and is reflected by reduction in aortic and diastolic pressure and subsequent systolic pressure. A trigger is the signal the Iabp console uses to identify the beginning of the next cardiac cycle. The trigger sources are ECG, pressure, ventricular pacer, atrioventricular pacer, atrial pacer, or internal mode. The trigger is the way the Iabp identifies the beginning of the cardiac cycle. There are 5 ways of triggering which can be used. ECG. It uses R wave on the ECG to initiate the pumping. Pressure mode. The arterial pressure waveform is used to trigger. It inflates at the point of dicrotic notch. Internal mode. This allows a synchronized trigger set at 80 beats per minute. Internal mode should never be used if a patient is generating a cardiac output, and it can be used during CPB for creating pulsatile flows. Pacer V or Pacer AV mode. It uses the ventricular spike to trigger an event, and it is not an appropriate trigger for demand pacing. When it is 100% on ventricular pacing or AV pacing, it can be used. Pacer A mode. The R wave on the ECG is the trigger. The atrial pacer spikes are enhanced and rejected. This mode is only used if ECG trigger is not able to interpret the R wave with atrial pacing. Never use if patient is ventricularly paced. Balloon pressure waveform's height or amplitude of the waveform is very important to determine bradycardia, tachycardia, hypotension and other possibilities like helium gas loss, catheter kink and sustained inflation. The balloon pressure waveform represents the helium movement between the console and the Iab catheter. It is shown as a calibrated continuous waveform allowing objective assessment of the safety and effectiveness of counterpulsation. This is the console screen where it has various informations like ECG trace, arterial trace, augmented diastolic pressure trace, helium tank gas level, alarm information, ECG leads, balloon pressure waveforms and balloon status to see whether it is filling adequately. It also has several modes and buttons which has start, operation modes, trigger sources, frequency ratio, augmentation level, manual filling, inflation and deflation timing adjustment, inflation intervals on waveform, etc. The balloon may be set to inflate at different frequencies 1:1 ratio, 1:2 ratio or 1:3 ratio. At the 1:1 ratio, the frequency of the balloon inflates and deflates with every cardiac cycle, providing full support to the patient. Each systole and diastole is assisted and augmentation is achieved with every cardiac cycle. At the 1:2 ratio frequency, the aortic balloon inflates and deflates once every other cardiac cycle. At the 1:3 ratio, the intra-aortic balloon inflates and deflates once every third cardiac cycle. This frequency is most often used when the patient is being weaned from counterpulsation support. Timing is referred to the positioning of inflation and deflation points of the arterial pressure waveform for proper augmentation. It's very important to know the peak points like unassisted end diastolic pressure, unassisted peak systolic pressure, diastolic augmentation or peak diastolic pressure, assisted end diastolic pressure, assisted peak systolic pressure, and dicrotic notch in the arterial blood waveform. From unassisted end diastolic pressure to the assisted end diastolic pressure is completing one full cardiac cycle as mentioned there. When assessing the arterial waveform, the hallmarks of optimal timing includes the following measures: a sharp V at the dicrotic notch followed by the increase in the diastolic pressure. Diastolic augmentation is ideally more than the systolic pressure. Reduced aortic and the diastolic pressure, which is referred as assisted end diastolic pressure reduction in subsequent systolic pressure, which is referred to as assisted systole. This increases the mean arterial pressure. The shaded area is the balloon augmentation. The precise timing of balloon inflation and deflation is essential to achieve the hemodynamic effects that increases the coronary blood flow and decreases the workload of the heart. Proper IABP timing can be achieved when the inflation occurs at the dicrotic notch, which should appear as a sharp V as shown in the previous slide. Ideally, diastolic augmentation rises above the systole, and the deflation occurs just prior to the systolic ejection and results in a reduction in assisted end diastolic pressure, results in a reduction in assisted systolic pressure. The efficiency of intra-aortic balloon pumping depends on the accuracy of the inflation and deflation timing settings. It is imperative that the user should fully understand the hemodynamic signs of proper timing and the adverse effects of improper timing. Even if your IABP adjusts and sets timing automatically, timing assessment should be done manually to confirm proper augmentation. The steps for assessing the proper timing is as follows. First, change the assist ratio to 1:2, print a strip and put IABP back on 1:1 assist ratio. Locate the dicrotic notch. Towards the left of the dicrotic notch, mark 3 peak points and 3 low points. Label all the landmarks. Using the rules of timing, assess proper inflation and deflation. Dicrotic notch is located and towards its left 3 high points and 3 low points are identified and marked. Now all the identified landmarks are labeled as shown in this picture. The shaded area is the balloon augmentation. Now apply the rules of timing by first drawing a reference line just at the dicrotic notch and the second reference line at the assisted end diastolic pressure as shown, and finally draw the reference line at the peak of unassisted peak systolic pressure. For proper inflation timing and to produce a rapid rise in aortic pressure for optimal augmentation, thereby increasing oxygen supply to the coronary circulation, rule number 1 has to be applied. Inflate just prior to dicrotic notch, which should result in diastolic augmentation which is greater than unassisted peak systolic pressure. and the inflation point should be a sharp V. For proper deflation timing and to reduce aortic end diastolic pressure, that is the afterload, thereby decreasing myocardial oxygen demand while improving the cardiac output, the following rules has to be applied. Rule number 2. Assisted end diastolic pressure should be lesser than or equal to unassisted end diastolic pressure. Rule number 3. Assisted peak systolic pressure should be lesser than unassisted peak systolic pressure. You can see balloon inflation point is just prior to the dicrotic notch, which results in diastolic augmentation or peak diastolic pressure greater than unassisted peak systolic pressure, satisfying the proper timing of inflation. This is rule number 1. You can see through the reference line that assisted end diastolic pressure is lesser than or equal to unassisted end diastolic pressure. This is rule number 2. You can see through the reference line that assisted peak systolic pressure is lesser than unassisted peak systolic pressure, satisfying the proper timing of deflation. This is rule number 3. To summarize and confirm proper timing of inflation and deflation, these 3 timing rules has to be checked. Now let us see about the timing errors. Inflation or deflation timing errors can be made in 2 ways, too early or too late. 2 of these errors, early inflation and late deflation, are considered potentially risky to the patient. Late inflation and early deflation are considered suboptimal, as the patient may not receive the full benefits of intra-aortic balloon pumping. Although not risky in themselves, late inflation and early deflation may cause further deterioration of myocardial status due to the lack of benefit. This figure shows the early inflation. Assess the position of the dicrotic notch by the assisted systole, and you can see that inflation occurs too far before, that is earlier to the dicrotic notch, and it violates the rule number 1 of balloon timing for inflation. The waveform characteristics of the early inflation are the inflation of intra-aortic balloon prior to the dicrotic notch, diastolic augmentation encroaches onto the systole. Sometimes it may not be able to be distinguished. The physiologic effects of early inflation are potential premature closure of aortic valve, reduces the stroke volume or cardiac output, potential increase in LV-EDV, LV-EDP and PCWP, increased left ventricular wall stress or afterload, aortic regurgitation, increased myocardial oxygen demand. This figure shows late inflation. Assess the position of the dichrotic notch by the assisted systole, and you can actually see the dichrotic notch where it should not be seen. Inflation occurs after the dichrotic notch, and it violates the rule number 1 of balloon timing. The waveform characteristics of late inflation are inflation of intra-aortic balloon after dichrotic notch, absence of sharp V, suboptimal diastolic augmentation. The physiologic effects of late inflation are augmentation less than the optimum, decreased perfusion pressure, and decreased volume to the coronary arteries. This figure shows early deflation. In the evaluation of the pressure landmarks, there is no reduction in the assisted systolic pressure. Unassisted peak systolic pressure is equal to assisted peak systolic pressure, and you can see a U shape at assisted end diastolic pressure. It clearly violates the rule number 3 for deflation. The waveform characteristics of early deflation are deflation of intra-aortic balloon is seen as a sharp drop following diastolic augmentation. Suboptimal diastolic augmentation, assisted end diastolic pressure may be equal to or less than unassisted end diastolic pressure. Assisted systolic pressure may rise. The physiologic effects of early deflation are suboptimal coronary artery perfusion, potential for retrograde coronary and carotid blood flow which may result in angina, suboptimal or no afterload reduction, increased myocardial oxygen demand. This figure shows late deflation. In the evaluation of the pressure landmarks, there is an increase in the assisted end diastolic pressure. Assisted end diastolic pressure is greater than unassisted end diastolic pressure. It clearly violates rule number 2 for deflation timing. The waveform characteristics of late deflation are assisted end diastolic pressure may be equal to or higher than unassisted end diastolic pressure. Rate of rise of assisted systole is prolonged. Diastolic augmentation may appear widened. The physiologic effects of late deflation are increased workload of left ventricle, afterload reduction is essentially absent, increased myocardial oxygen consumption due to left ventricle ejecting against a greater resistance and a prolonged isovolumetric contraction phase. Intra-aortic balloon may impede left ventricular ejection and increase the afterload. To summarize the timing errors, inflation has to occur just prior to the dichrotic notch. If balloon is inflated greater than 40 milliseconds before dichrotic notch means it is early inflation. If dichrotic notch is visible means it is late inflation. In deflation, assisted peak systolic pressure should be lesser than unassisted peak systolic pressure. If both pressures are equal means it is early deflation or afterload reduction not required. Assisted end diastolic pressure should be lesser than or equivalent to unassisted end diastolic pressure. If ADIA is higher than DIA means it is late deflation. Steps for initiating the IABP. Power on the IABP. Verify helium supply is present. Connect ECG source. Connect arterial pressure source. Zero the arterial pressure. Connect IAB catheter according to the selection. Select trigger source. Keep augmentation to 100%. Press start button. Assess the timing by putting frequency to 1:2 ratio. After correcting the timing of inflation and deflation, put back the frequency to 1:1 ratio. Monitoring during IABP. Hourly monitoring of heart rate and rhythm. Pedal pulses distal to the catheter site using the Doppler. Left radial pulse has to be checked to confirm there is no compromise on the blood flow to the left subclavian artery. Color, temperature and capillary refill. Sensation and movement of both lower extremities. To confirm there is no compromise to the blood flow of the kidneys, check the urine output for renal function periodically. Systolic, diastolic and mean arterial pressures and diastolic augmentation should be monitored. Use the BP obtained from the IABP while titrating the drugs. Should not take blood samples from the IABP catheter because it can cause risk of embolism. Care during IABP. Carefully monitor the insertion site for signs of bleeding, infection, hematoma or compartment syndrome of the limb where IAB is placed. Assess insertion site each shift for redness, ooze. The balloon should not remain immobile for more than 20 minutes while in situ due to the risk of thrombus formation. Heparinization according to the protocol may be initiated at 24 hours. For arterial flush bag, use normal saline 500 ml with heparin 1000 international units. Patient to be log rolled and the end of the bed elevated not more than 30 degrees to prevent catheter migration or kink and arterial puncture. Steps for weaning of IABP. Weaning can be accomplished by decreasing the frequency and or volume of the balloon inflation. If planning to wean off IABP by decreasing the frequency, reduce the frequency to 1:2 ratio to 1:3 ratio gradually. If planning to wean off intra-aortic balloon by decreasing augmentation, reduce the volume delivered to the balloon not less than 2/3 of the capacity of the balloon. Monitor the following vital signs while weaning off IABP: ECG, heart rate, blood pressure, urine output, cardiac output or cardiac index, mixed venous saturation. Make sure the following clinical picture is present prior to discontinuing the IABP. No hypertension due to the low cardiac syndrome. The urine output should be maintained above 0.5 ml per kg per hour. Requirement for positive inotropic agents is minimal. The cardiovascular system remains stable in the low dose range. The heart rate is less than 100 beats per minute. Ventricular ectopic beats are fewer than 6 per minute, not coupled and unifocal. The cardiac index remains equal to or greater than 2 liters per minute per meter square and does not decrease by more than 20%. The index of LVEDP does not increase to greater than 20% above pre-weaning level. Absence of angina. When the patient is no longer requiring IAB support, press the standby key to stop the pumping. Then remove the IAB according to your hospital policies and procedures. Removal of a percutaneously inserted balloon catheter can be done quickly and safely without an operative procedure. Disconnect the balloon from the console. Remove the balloon and sheath if used simultaneously. Allow proximal bleeding for 1 to 2 seconds to encourage extravascular loss of thromboembolic material. Apply firm pressure immediately to the femoral artery insertion site for at least 30 to 40 minutes or more if patient is heparinized, and then apply a pressure dressing. Post-removal care includes the continual assessment of circulation to the cannulated leg by monitoring and recording of peripheral pulses at regular interval. Transporting the IABP. While transporting IABP, it is highly recommended to keep a fully charged battery in the console or a UPS supply, making sure the helium tank is at least 50% full. While air transporting the IABP, for a proper operation during air transport, IABP balloon pressure must adapt to local atmospheric pressure. In the autofill mode, the system will automatically purge and fill the IAB when local atmospheric pressure decreases or increases by 25 or 50 mmHg respectively. These pressure changes occur approximately every 1000 feet of rise or 2000 feet of drop in altitude.